Hi, I'm Pat Iyer, a legal nurse consultant for the Physician-Patient Alliance for Health and Safety. This is a nonprofit organization dedicated to improving patient safety and health. With me today are three people who have a very special story to share. Michael Wong, who is an attorney, and Cindy and Brian Beal, who are the parents of a young woman who had an unfortunate experience, an unfortunate outcome with a patient-controlled analgesia pump. What I'd like to do is to share a little bit about what the pump is to give you a context so that you'll understand the information that is going to be following. A patient-controlled analgesia pump was designed and started to be used in, I think, probably roughly the 1990s as a way of providing better pain control than patients putting on their lights in a hospital and waiting for a nurse to answer the light and then to go up and draw up a medication and come back and inject the patient. The button on the patient-controlled analgesia machine allows the patient to push it to get a dose of a powerful pain-relieving medication such as morphine or Dilaudid, both of which are very strong and powerful intravenous drugs. Patient-controlled analgesia machines, or PCA pumps, offer that immediate relief from pain, but they carry certain risks associated with their use. And those risks were not really well understood at the time that pumps were introduced and are becoming better understood as time goes on. In fact, there was a study that was done by the U.S. Pharmacopoeia and Medmarx, which showed that PCA pumps increase the risk of patient harm by 3.5 times. Nurses and doctors who are involved in PCA pumps are expected to understand how to operate them, program them, and to identify which patients are not appropriate to use PCA pumps. And those include people who are confused and elderly, people who are obese or have difficulty breathing at night called sleep apnea, infants and young children, and people who are taking other medications that could increase the effect of the opiates, such as sleeping pills or muscle relaxants or drugs to control nausea. So there are a number of risks associated with this machine, which I think that we'll probably get into as we go through our conversation. And I'd like to start by asking Michael some questions about his organization. Can you tell me about the group that you have been involved in starting?
Yes, Pat. The Physician-Patient Alliance for Health and Safety is an advocacy group. It doesn't really have currently the structure that you'd expect from most organizations. As you might appreciate, there are prominent physicians and healthcare providers that have been helping out. Most of their names, I believe all of the names, are on the website currently, and depending on their time and availability, they have helped in different ways. Some of them have provided comments, some have provided advice, and of course one of the things that we're targeting now, which is why you made the call to us, is regarding PCA pumps. But it's an alliance that's dedicated to improving patient safety and health outcomes, and as I said, PCA is just one of the things that we've targeted, and clearly, a very important one.
Mm-hmm. Could you give an explanation or help us understand some of the kinds of activities that the organization is involved in? I know you have a website and lots of articles on it.
Yeah, well, obviously there's been a concentration on PCA pumps, but as well there has been an emphasis on providing case studies that improve health outcomes and reduce costs. And so that's also been an emphasis. But PCA very early on was identified as an area, and as you've cited the Medmark study, cited as an area that we should target, and so that's what we've done. And I think that Amanda's story and a number of the other stories that have appeared on the Physician-Patient Alliance site are really testaments to that. For better or worse, Amanda, sadly, is not the only one. There's certainly other individuals who have passed away because of respiratory depression or the lack of monitoring, or rather both of them. And so that's become a very clear and important initiative for the Alliance.
What stimulated you to start this group?
That's a good question. Cindy's smiling at me because I told her this last night at dinner, but over the summer, last summer, some of my physician friends had commented to me that I was not at that point involved in a healthcare initiative. I've been involved in many healthcare initiatives in the past, smoking cessation, hepatitis, pain management, MS. In some way, each of those causes and many others have been ones which I've taken up, and initially got started with a friend of mine, Howard Snitzer, who had had the good fortune of surviving 96 minutes without a heartbeat, thanks to the use of capnography, which measured the rate of respiration. And it showed his paramedic rescuers that he was still alive and breathing, or at least breathing out CO2, enough for them to not quit at the sort of usual sort of 15 or 20-minute mark. And so they had more than 20 volunteer paramedics working on him for 96 minutes as the Mayo Clinic flew in a helicopter to take him to the hospital. So that was a good, how do I say it? That was a good story.
It is a good story. It's a very unusual one.
It's a very
Many people would have
one.
been zipped up into a body bag before that happened.
Well, I think, I think a lot of people, a lot of paramedics would have given up on him at least the 20-minute, 15 or 20-minute mark. But not only that, not only did he survive, but if you talk to Howard, he's as lucid as I am. Maybe not that lucid, but as lucid as I am, and a lot of great things came about it. He lost a lot of weight, 100 pounds, if my memory serves me right, quit smoking. So he's a testament to it. And I remember his words when I spoke with him just before launching the Physician-Patient Alliance website, and he said to me, Mike, if what we can do can save one life, then it's worth it. And so with that sort of inspiration, the first story was told, and it's gone on from there. I was sort of secretly hoping when I first did that first story on WordPress that that we would follow it with other good stories, but unfortunately we didn't. We were approached by other families that, like the Abiels, like Lenora Alexander, Leah, whose teenage daughter also died in sedation as well, and she was not monitored. So sadly, while I wanted to kind of make this a good field site, it quickly became these are the phases of tragedy, and what can we do about it? And so that's why I turned back to my physician friends and said, what can we do about it? And not only did we look into how often PCA errors and adverse events and respiratory depression occur, but what can we do? And what we thought of is I don't want to call it a cheap alternative, but certainly a very inexpensive one because it'll be free, a checklist, a safety checklist targeting PCA use. And that is currently being developed today as we speak. It's in the draft number 5 mode, and hopefully soon it will be available.
All right. Tell us a little bit about your background. You mentioned being involved in several health initiatives, but I understood that you are an attorney, so I'm a little confused.
I am an attorney. I help out pharmaceuticals with some of their crisis management and things like that, and I've been doing that for quite a number of years. But I like to think that my work like this with the Physician-Patient Alliance and with the OPILs is really more important than anything else that I can ever do.
I understand.
As Howard tells me, Howard Snister tells me, we can save one life. We've done a good thing. And you know, even if it's late at night writing an article, I keep his words at heart and continue to do these things. So.
Well, I wanted to give our listeners a little bit more of the medical background, because we're going to be talking about pulse oximetry and capnography, and those are, to lay people, terms that they may never have heard before, but might have some concept of the pulse oximeter if they've been in a hospital and seen a little clip that goes onto a finger, which measures the oxygen saturation of the blood. And it is typically available for people who are going through surgery. It may be put on a finger of a patient on a medical surgical unit once every 8 hours or so. And it has been around for quite a number of years, probably at least 15 years. A commonly available and inexpensive method of monitoring. Continuously leaving the pulse oximeter clip on the finger of a patient on a medical surgical unit, which is a general hospital floor, is not as common. But capnography is a little bit more current in terms of its technology, a little bit newer of a technique, and it is a way of measuring how much carbon dioxide a person breathes out over time. If you think of an EKG monitor of that you've all seen, of the little peaks and valleys of a typical heartbeat, the capnography displays on a monitor screen like that. And it typically has a waveform that looks like, if you're looking at a table, at the end of the table, you see the leg of the table, you see the flat part of the table, and you see the leg down. The capnography machine creates a wave that looks somewhat like that, except that the right-hand corner, if you're looking full at the table, is up a little bit higher. And that wave corresponds to different parts of the breathing cycle. The way that, just like with an EKG strip, with the way that the peaks and valleys occur, in a capnography machine, the way that the little table is created also is significant. Whether that shows widening areas between breaths or it shows shallow breaths will appear on the capnography machine. And one of the issues that is associated with PCA pumps is to pick up people who are receiving too much in the way of pain medication, which is causing the respiratory depression that Michael referred to earlier. The potential for receiving too much medication may occur if the doctor orders too strong of a dose of the morphine or the Dilaudid, or if the nurse who is setting up the equipment programs the machine with an incorrect concentration or a wrong dose, and no one double checks that and picks up the error. Those are two common issues with the use of PCA pumps. An issue that we have had a harder time with in the past is whether there would be a continuous infusion of the pain medication over a course of time. And that was called a basal rate, and it is no longer common. That's B-A-S-A-L. So in other words, what physicians used to do was to order that a patient would receive a continuous infusion of morphine, for example, 5 milligrams per hour, for example. And then when the patient pushed the button, the patient would receive an additional dose of morphine. What happened is that patients were being over-sedated by that continuously running infusion of morphine. So the trend now is to stop ordering the continuous infusion and only have the pump set so that it will provide medication when the patient pushes the button. So that gives you a little bit of background in what we're going to be talking about in terms of monitoring people with oximetry and capnography. And Michael, I didn't know if you wanted to say anything else about your organization and how you got involved before we talked to Cindy and Brian.
Well, I think your explanation of oximetry and capnography are excellent, and I think the only thing I would add to it is that both devices on a patient provide that electronic safety net, if I could call it that, that would alert staff to healthcare providers that potentially the patient is falling into respiratory depression. And in particular, and this is why Wolf talked about capnography many times on the PPAHS site, is capnography is because capnography, as you mentioned, measures the rate of respiration or the adequacy of the respiration of the patient. And in a demonstration that one provider did for the class at Notre Dame, is we had a nurse put on a capnography device, and she held her breath, and immediately the capnography waveform, as you described, flatlined, and that indicated that she was not breathing, and the oximeter didn't move at all. It still stayed the same because obviously the oxygenation of her blood still continued to be maintained at a normal level. So when she held her breath, the capnography indicated that her rate of respiration had gone down, and if that had been live, in the sense of being in a hospital, the alarm would have sounded, and a nurse would have come in and checked on the patient. So that's a stark example of why oximetry and capnography need to be used, and in particular capnography, to measure the adequacy of respiration. So that's why we've emphasized it a lot. And I think as you talk to Cindy and Brian, they'll say the same thing as well.
All right. Well, that's a really good explanation about why one machine is not effective alone, but you need both of them to provide a picture of not only the oxygen but also the carbon dioxide that's in the blood.
Correct.
And what I'd like to do is to talk with Cindy and Brian about their experience, and to have whoever would like to go first give us some understanding of who Amanda was and why she came into the hospital.
Forgive me if I start to break up and cry on you, okay? A very outgoing and loving child. She was very diverse. She had a lot of friends. She had a lot of different types of friends. She had friends who were very wealthy. She had friends who were very poor. She would drop anything for anybody. She went into the hospital mainly with a virus for and dehydration. And by the time we got into the hospital, she'd had a fever, so they knew that there was something going on more than just rehydrating her. Put on the pain pump, went in on a Thursday, Friday evening she was put on the pain pump, and by Saturday morning she had passed away. She was our only daughter.
Wow.
From a personal standpoint, Brian and I will never be able to see who she marries. I'll never be able to pick her wedding dress out with her. We'll never be able to have her father-daughter dance. We're just going to miss.
And how old was Amanda when she died?
She was 18.
Very young.
Very young, very beautiful inside and out. The best way to describe her in one sentence is that when she walked into a room, she brought the sunshine with her, whether it was storming out or not.
Mm-hmm.
She was both of my children, I have a son and a daughter, were never afraid to tell you that they loved you. Even when they were middle school and in the awkward ages, we got hugs and kisses from them all the time. So by that, we're very thankful for that, because she never left the house or the room or anything and went anywhere without telling us she loved us and without us telling her the same. So I think we had a phenomenal daughter, and I think she is pushing us every way she can to get this done.
Mm-hmm. Tell me a little bit about why she was put on a PCA pump if she went in for a virus. Well, where was her pain?
She had started to develop sores in her mouth, which was, some type of virus, according to the doctor. She really wasn't able to get relief. So, she was scheduled for morphine dosage, initially when she was first admitted to the hospital. That really wasn't working out. So, it was basically, as my wife stated, a day later, it was determined that, a PCA would work better. And that's what was done.
And I think, and this is Michael, I think I know that the Alveals, Brian and Cindy, are pointing out the dangers of PCA. I think what Brian alluded to is there are clearly a lot of benefits to PCA that the studies have shown. Generally, better pain management, better allocated. But in Amanda's case, she was not monitored with a capnography machine, and had she I believe, had she been monitored, the nursing staff at the hospital where she was staying would have been alerted, and might have been able to know that she was suffering from respiratory depression, and could have been able to do something. So,
I know that we're walking a little bit of a delicate walkway here, because there are restrictions on what Cindy and Brian can discuss during this interview. Could you outline those restrictions so that I don't stick my foot into it?
Well, in all honesty, what we really want to talk about is just really the awareness that we would like to go forward with for not only the public, but hospital administrators, hospital staff, and the patients themselves and the patients' families. So really, our main statement is that about 12 and a half hours after she was put on Dilaudid, she was found unresponsive. It'll probably never be 110% for sure what's happened, but we feel that the continuous monitoring is definitely an important issue, and I guess it's our feeling that what really happened to Amanda maybe shouldn't really even be the issue so much as that the capnography along with the pulse oximetry, can and does save lives. And that we had no idea what respiratory depression was. We had never heard of capnography. And we would just like to make sure that other folks understand a whole lot more about it than what we did.
Well, it's understandable that it was new territory for you because it is a technology that is not, or it used to be not commonly available, and I think that everyone who goes into a hospital or a family member with a patient makes assumptions about the nurse's abilities to monitor and the equipment's ability to be used properly. And that is one of the weak areas when we start using machines that have the potential for not being properly set up, or nurses who are overloaded with other responsibilities and don't always spend the time monitoring that they should. I'm talking in generalities because clearly I don't know anything about what happened to Amanda in terms of what was the cause of her going into respiratory depression, but I have reviewed several cases as a nursing expert witness involving patients who went into respiratory depression while they were on PCA pumps. So I have an understanding that comes from other cases independent of anything that Michael might have been involved in or any of the stories on Michael's website. But tell us a little bit more. Go ahead.
Well, one other thing I think is important to add is that, it's our understanding at this point in time that there really, to the best of our knowledge, there really aren't any hospitals in northern Indiana that presently use continuous monitoring with pulse oximetry and capnography. So, that's one of the things that, that is our agenda, is to change that.
I know, Michael, that you mentioned to me earlier that there are some hospital systems, Candler Hospital and the VA, who are breaking new ground by implementing this type of continuous monitoring. I also know that there are manufacturers developing or in the process of or have already developed PCA pumps that build in the monitoring equipment as part of the machinery. Can you talk to us a little bit about what you understand in terms of the trends with that type of equipment?
Yes, maybe I can relate to what Veterans Affairs Health Administration have done. Now, speaking with Brian Patel, who is a biomedical engineer there, and when they did their analysis of adverse events that had occurred in the VHA system, they found a high percentage of these adverse events were caused by or were related to PCA use. And so what they did, or what Brian Patel has described to me what they did, was they brought in PCA pumps that had integrated with it a capnography monitor. And as I'm not an engineer, but as Brian told me, what happens when the capnography monitor senses the patient is going into respiratory depression, it actually shuts down the PCA pump. It's what he calls what he calls a forcing function. And so it would shut down and then alert the healthcare staff. So I think that's a critical aspect of what capnography monitoring can do. And in the case of St. Joseph Candler, they had 2 or 3, fortunately no deaths at that time, 2 or 3 adverse events about 10 years ago, and that prompted them to review the literature and look at what are the best options for avoiding this in the future. And they decided to go with a smart pump that had the integrated capnography monitoring in it as well. And I don't have all of the numbers at my fingertips, but they calculated that they saved approximately $4 or $5 million in doing this over that period of time. And so I think a lot of hospitals, in looking at it, and I understand budgets and the economy, that it did cost some money to acquire the equipment, but they calculated that they actually saved money by doing that. And of course, even more importantly, they saved lives.
Mm-hmm. And the costs are not inclusive of the $4 to $5 million. There's also the costs of litigation for the medical malpractice suits that they have avoided. There's the cost of human life and all of the associated aspects of that. I mean, that's really a commendable beginning.
It absolutely is. I think you've hit it right on, Pat. I mean, those costs are just the costs that they avoided in terms of expenses. It didn't include any of the costs of litigation. And of course, as you know, as a legal nurse consultant, when you get into court, that damage judgment could be significantly high, and that could almost shut you down. So that did not include that assessment. That's just on the average medical costs that were going to be avoided by introducing integrated capnography monitoring with their PCA use. And I know St. Francis Hospital, and we're going down to see them tomorrow. They've introduced this as well into their facility, and so they're using the integrated capnography monitoring with their PCA pumps, and we're eager to hear their full story. What happened to them? Yeah.
Mm-hmm. I thought I would give our listeners a little bit more information about why some of these respiratory depression incidents occurred, and I think that helps in understanding why having the electronic monitoring in place is so important. The button that is pushed by a person to get a dose of morphine can be confused with a button that's used to call a nurse to the bedside. So if a patient is pushing the PCA button thinking that he or she is calling a nurse and the nurse doesn't come, then the patient may call the button again or push the button again and therefore inadvertently give himself or herself more morphine than expected. One of the ways that the equipment companies have addressed this is to make an audible sound so that when you press that button, you're hearing that that's the PCA button. But that also assumes that the person is alert and can tell the difference and understands this button is for the pump and the other button is for calling the nurse. Some hospitals have gotten around this by making a very long rectangular call button device that doesn't look in any way at all like the PCA button. Another source of people getting too much pain medication has been family members, well-intended family members or nurses who have pushed the button for a patient who is too sleepy or too groggy to push the button herself, for example. Source of medical error that was recognized about 5 years ago. There was a lot of discussion in the patient safety literature about the idea of what's called PCA by proxy meaning by another person. Nurses used to go in and push the button for the patient, and in one medical malpractice case that I reviewed, a wife was instructed by the nurses to push the button for her husband when he was too sleepy to push the button himself. The issue in that case was that the well-intending wife was giving her husband too much pain medication and thereby became part of the chain of events that led to him being over-sedated. The nurses denied when they were deposed that they had ever instructed the wife to push the button, but she was very convincing in her deposition and said, I never would have touched the equipment if I hadn't been instructed. I was taught that if he couldn't do it for himself, I should do it. The issue with having somebody else push the button is that if the patient is too sedated to push the button himself, it means that he has enough pain medication in his system and doesn't need to have somebody else giving him additional. Another issue that comes up, and we've talked about monitoring, is that if the nurses are very busy and are not checking respiratory rate or not checking the person's level of awareness or the ability to respond, that the individual can become over-sedated or heavily sedated and is not therefore awake enough to be able to say, you know, I'm too groggy, I'm getting too much pain medication. That person can't communicate that, so it's up to the nurses to monitor the condition of the patient and pick up when the patient has developed these signs, these warning signs, slowed respirations, inability to be awake and alert. And that's why the capnography and the pulse oximeter machine are so important to act as those electronic warnings. And a third area that I have seen in the cases that I've been involved in is that there is a rescue drug called Narcan that should be readily at hand when a person has received too much pain medication. The Narcan acts as basically the equivalent of a shot of adrenaline into the system. It helps to counter the effects of the pain medication, make the person get a reversal of the pain medication so that the person becomes more awake, and it basically chases the opiate out of the system, the opiate meaning the narcotic or the pain medication. But it has to be given in a specific series of frequent doses followed by observation, maybe 3 to 5 minutes apart. One case I was involved in, the nurse gave one dose and thought that she didn't have to give any more and walked out of the room, and 45 minutes later came back and checked the patient, and the patient had died because not enough Narcan was given frequently enough. So that's another aspect of the risks associated with PCA pumps, is to make sure that individuals know that Narcan should be available, should know the protocol for giving it, should know the monitoring that goes along with giving somebody Narcan. This is really a medical emergency that takes place whenever Narcan has to be given, and everyone needs to understand the routine. So having electronic monitoring to prevent people from ever needing Narcan would be the objective. And I thought we would go back to Brian and Cindy and ask them, what messages would you like to share with health providers about your experience and how to avoid some of the kinds of issues that we've just been talking about?
Well, I think one thing that we learned, and I think the hospitals would probably agree with us, and in that I think everybody has to be kind of an advocate for their loved one who's in the hospital. I think, that's something that maybe you don't think of initially. As you mentioned earlier, the nursing staff, they're taxed. There's obviously cost to consider. Maybe the night shift is even to a lesser degree than the day shift or whatever the case may be. But I think that, that's an important thing for people to realize. And it's nothing to take away from the hospitals. I don't think it matters, what hospital you go to. I think you need to be aware of, what's being done and what's going on with your loved ones.
Mhm. Mhm.
Another thing, maybe a little off the beaten path, is I think it's important for people to understand that, from our reading, anyways, and the understanding from talking to people that that I'm under, a person doesn't have to be overdosed with medication in order to have respiratory depression. I think that's kind of a misnomer that I think a lot of people believe, is that they have to be OD'd in order to have this problem. And at least certainly from what I've read and the way I understand it, that's not really the case. I mean, yes, they've had more than they need, but if you do the computations and look at the person's body weight, and, however all that's done, I'm not trying to tell you I know, because I don't. But respiratory depression certainly can set in well within those limits. It doesn't have to be outside those limits. A person doesn't have to OD to have respiratory depression.
That's a good point, because there is a misunderstanding on the part of nurses that if a PCA pump is ordered and the patient can receive, for example, 1/2 milligram of morphine every hour, that the patient cannot develop respiratory depression if the order is followed and the pump is set up correctly. And that is certainly not true because of the variables, the other medications, or the weight of the patient, or the way the patient is clearing anesthesia out of her body after surgery. You can still end up with respiratory depression even if the instructions are followed on the pump. And that's why that observation and what you've talked about in terms of the electronic monitoring is so important.
Yeah, I think this is Michael. I think that you make a great point, Pat, because in other words, no error, no human error might have occurred. The pump, the folks that have programmed the pump, the nurse that programmed the pump, may have done exactly as he was told to do. And the nurse that came in that checked on to make sure that the pump had been programmed correctly may have done exactly what she was told to do. There may have been no human error at all involved, and yet the patient would have suffered respiratory depression. So you make a great point that that could have occurred, and it's really only through observation and assessment and continuous electronic monitoring with oximetry and capnography that would have detected a potential respiratory depression event occurring. So you make a great point. Thank you, Pat.
And this is probably off the beaten path also, but Amanda has several very good friends who are heading to school for nursing or are in nursing school. And the one thing this is in no way, shape, or form to down the nursing staff of any hospital, but the one thing that I've told these girls and anybody that I talk to that's going into the field, before you enter that patient's room, I don't care if it's a male patient, female, a baby, a toddler, a teenager, a grandparent, treat that person as if that's who your relative is. I mean, take care of that person like you would if it was your father, if it was your mother, if it was your sister. And I'm not saying Amanda didn't have that care. She did in some aspects, but obviously she didn't in other aspects. So, you know, to me that's an important learning tool for the nurses. I know that they go into the field, you know, with great intentions. I mean, everybody does. But at some point, you know, I think that they have to take a step back before entering that door and take a big breath and figure out who they're going in to talk to and treat them as if they were a family member.
You know, that's an interesting point, because one of my authors is a nurse from West Virginia who writes about stress and the impact on healthcare providers. She gave me a column yesterday on compassion fatigue, which is a way of describing how healthcare providers can get overloaded because of being constantly exposed to suffering and stress and trauma and the demands of the job, to the point that they start cutting their own needs short. You know, it's very common in certain nursing units for nurses never to stop and eat a meal, including in a 12-hour shift, to just keep pushing themselves and pushing themselves, much less being able to run to the bathroom. And that constant level of demand and stress can cause nurses to miss things, to get jaded, to get sarcastic, to get callous, and not because they went into nursing school like that, but the job demands, and not being able to take care of themselves or not recognizing how to take care of themselves properly can bring them to that point. And, you know, they may not recognize themselves that dread of having to go to work, or feeling negative, or feeling so tired that they can't function, but literally they can cause consequences and medical errors and a lot of patient dissatisfaction by getting burned out to that point. So the girls who go into nursing school often enter the field in a very idealistic state, and then find the realities of being able to function in today's healthcare environment may be very different than what they expected.
Yeah,
I agree.
and you know, I think we've been talking about it, you know, really from a daily nurse's point of view, because they're the ones, and I don't want to denigrate physicians at all, but the nurses and the respiratory therapists and others are the ones that have to take care of the patient, or do take care of the patient once they get out of surgery, you know, once whatever procedure has been done to them, and you know, give these nurses and the respiratory therapists the tools to help them do their job. You know, as Abdul has said, you know, continuous electronic monitoring. You know, if I was a nurse, I'd prefer to have be told that my patient's suffering from respiratory depression than all of a sudden coming in the room and finding my patient's dead.
Yes.
You know, those are the awful alternatives. And, you know, when I've talked to nurses across the country about sort of, you know, what have you implemented and that kind of thing, I think in the places that have implemented capnography monitoring for PCA pumps, that's something that gets said. It's really reduced the incidence, if I could put it that way, in my day, because then I know that something is happening. And it's almost like a nurse's aid. So that's a great point that you make. You know, really help out that nursing staff. And I think of Matt Whitman, and I know we referred to him earlier in our conversation. Matt Whitman, who by the grace of God survived when he was slipping into respiratory depression, and the nurse just so happened to be passing by his room, and he wasn't monitored. As Matt says, you know, I should have been monitored, because you know, then my nurse would have known, wouldn't just have passed by my room and by chance. She would have known. Come in my room and check me. So it's you know, at the end of the day, I guess you could call it a nurse's aid, a little safety net that's underneath the patient to help them out.
Yeah. I know that people who are listening to this are going to say, well, this is now so obvious. Why aren't all hospitals doing this? Michael, how would you answer that question?
Well, I understand that a lot of it has to do with, and I won't name the hospital, but I was speaking with the hospital, and they emailed me and they said, capnography is going to be the standard of the future. And I emailed back, well, why aren't you using it? And they said to me, well, we just bought PCA pumps. And we don't have any, basically the underlying message is we've spent our money, and I understand that. Mm-hmm. But I would also say to them, what money are you going to spend on all the patients that have adverse events or unfortunately die? That's an even bigger cost. I think, as IOM pointed out, the cost of an adverse event are almost $9,000, and that excludes legal fees, damages, and all that kind of horrible stuff that can happen if a patient dies or suffers injury. So, for those hospitals that are looking at expenditure, just think of the money you're going to save by spending some money today. And as well, that's one of the things why PPHS is producing a checklist, because we understand that hospitals today may not have the funds to actually buy all the equipment. So the PCA checklist is going to be a reminder that we're producing, a reminder of the essential 4 or 5 steps that they need to do to ensure that their patients are monitored correctly and hooked up to the PCA pump correctly, and then thereafter assessed on a periodic basis to ensure that they are safe.
Can you tell us a little bit more about the content that's going to be on the checklist? In other words, are these steps that are 1, 2, 3, 4, 5, or is it designed in some other way?
There are a series of 5 steps when a patient that we're recommending that a patient, that a caregiver, whenever a patient goes on a PCA pump, be observed, and then thereafter there are currently sort of 4 steps that are being recommended for caregivers to go through to ensure that the patient is safe and healthy. Right now, as I think I've told you, we are going through a number of drafts, and we're on sort of version number 5. I'm collecting comments from well-known healthcare providers across the country and assembling that, and hoping that in the next few weeks that we'll be able to publicly release the checklist for all hospitals and healthcare facilities to use.
That sounds wonderful. As an attorney, I know that you've had some exposure to the concept of the standard of care, and you and I have exchanged some thoughts about how this subject can be covered in this discussion. And the issue really is it now the standard of care to expect a facility to monitor with an oximeter and a capnography, or is that a standard of care that we are evolving into or will be current only in the future? Now, what are your thoughts about that, Michael?
Well, I think when a facility such as Veteran Health Administration implements this across the country, that sets that standard of care. I think that it's going to be really hard. I would say it's very hard for a hospital that has a Veteran Health Administration hospital near them to say, we're not monitoring with oximetry and capnography, but they are. And I think that does set a new standard of care. There are, other countries like the UK did a big study last year and determined that by using capnography, in their ICUs, they would have prevented a lot of deaths. So, you know, it's becoming a standard of care around the world, and I think that it kind of behooves us to not implement that standard of care, you know, here in the United States. You know, healthcare, you know, Veterans Health Administration, they've taken the lead. St. Joseph, Candler, down in Savannah, Georgia, you know, they've looked at it for almost 10 years, and with great success, and in terms of not only saving lives but saving dollars. And so I think there is a standard of care that is being set there. I'll turn that around, because you're a legal nurse consultant. I mean, what would you advise, you know, a client coming in or a lawyer coming in asking for your advice? I'd love to hear your opinion on it.
You know, it's something that's hotly debated in our field, because there's this concept of institutions and providers accepting new technology or new ways of doing things as measured on a continuum from the people who are the early adopters, you know, the people who went out and bought VHS machines and microwaves when they first hit the market, or the people who have the first generation iPad or bought the first iPhone. I'm responsible for having bought the first iPad and the first iPhone shortly after they were released. And then there are the people who are not interested in new technology whatsoever until it becomes inescapable that they have to adopt. Healthcare is very similar in that there are people who set the trends, who are well respected, who start doing something, and then it catches on. There's an issue of the fact that the healthcare in this country is different in different parts, and although we're supposed to all be doing the same thing, you might have a very different outcome if you went in for prostate surgery at a well-known prostate center than if you had prostate surgery done in your local community hospital. And we struggle with this issue. When it comes to identifying the standard of care, generally in the legal field, people look at what's in the medical literature, what was known at the time, what types of guidelines have been issued. You know, for example, if the government through AHRQ, which is the Institute for Healthcare Research and Quality, comes out with guidelines about how to manage a particular problem, that's very persuasive, that establishes and sets the standard of care, because that's generally very, very well researched with prominent people who are clinically aware and are knowledgeable about a particular area. So from a legal perspective, we look at those issues of how persuasive, how pervasive are those clinical aspects of care. How much was known at the time, because usually a lawsuit is filed within 6 months, a year, maybe longer after an incident, maybe up to 2 years later, and then people judge, well, what was known at the time of the incident that led to the lawsuit. So I think you will find, Michael, as time goes on and as the VA and adapting the technology, writing about their results, sharing information in conferences, talking to their peers about their great results that they're getting from this type of monitoring. As more equipment manufacturers make that available to hospitals, it's going to be harder for hospitals to resist the trend and to say to you, well, we just bought new PCA pumps. We can't possibly go out and get more pumps. Or, you know, response to that is, well, you have little portable or capnography monitoring equipment that can be independent of the pump, that can sit at the patient's bedside. You can still invest in that separate monitor even if it's not integrated into the pump. So that's a very long answer to your question. But it's a good one.
It is, Pat. I mean, one thing I would say, giving advice to someone, let's say a hospital, I prefer, to be proactive as a hospital and do something rather than have an adverse event or death occur and then have a jury decide what the standard of care is. When I talk to malpractice lawyers, and I say, what's the standard of care? And they say, well, the standard of care is anything I can convince the jury on.
Mm-hmm.
Right? I mean, the standard of care that you're talking about is maybe published in, by a medical society, that kind of thing. Yes, that is the standard of care. There's also standard of care, which is expected by the community. And, that's what a jury would decide in the case of injury and death. And I certainly wouldn't want to put my hands into a jury's hands just by saying, gee, I didn't think the standard of care was this. It was something else. Because, at the end of the day, they might decide against you. And I'm sure you're as a legal nurse consultant, you've certainly seen that as well. So.
Well, yeah, I've seen thousands of medical malpractice cases in the last 25 years, and I think that generally, as a broad generalization, the hospitals that are on top of the technology, that are implementing guidelines that are in the best interests of the patient, have a much easier time defending themselves if something goes wrong by pointing out to all the positive things that they did to try to prevent the issue. But unfortunately, the lawsuits tend to more center around the facilities that are behind the times or the people who are not taking advantage of what is known to create more safe healthcare environments. And they have a tougher time defending themselves. So it's a very mixed world in terms of how fast organizations implement what others know to be the safest course for patient care.
No, absolutely. And it could be just some simple procedure. My physician said, Mike, you're getting old. You should have a colonoscopy. And I go, I'm thinking about it. I say yes, and then I leave the office and think, well, are they going to use general anesthesia on me to do this? Or are they going to put me under? Are they going to monitor me? And I think there are some simple procedures that can occur. Kids that have died from tonsillectomies being under, wisdom teeth being taken out. There's all these lawsuits and cases that are out there. And it couldn't just be, it doesn't have to be for something what people would say is serious, in other words, going into a hospital. It could be, going to get cosmetic surgery and going to see your dentist, and instances where, you wouldn't expect anything to happen at all. I know that you had written about your experience as well with that. So yeah, you have to be, I think as a patient you have to be well aware of what's going on, and I think as a healthcare provider you need to be able to take as many precautions as necessary, because the consequences could be tragic.
Absolutely. Thank you for joining me today and sharing your perspective on patient-controlled analgesia pumps, pulse oximeters, and capnography. For more information on these important patient safety issues, check out the interesting articles and resources found on ppahs.org, Physician Patient Alliance for Health and Safety, a nonprofit organization dedicated to improving patient safety and health.